Dr. Megan Boston from University of Waikato, give us a brief introduction and then jump right into your presentation.
Well, thanks for having me. As just said, I'm Dr. Megan Boston, University of Waikato, civil engineer by training, structural space, did my PhD at Johns Hopkins, the civil and systems. What's now civil and systems. At the time it was just civil engineering, but they were incorporating systems type research and stuff, which my PhD fell under that category. So I'll just be presenting some follow-up work to what I did on my PhD and continue to work on today. I'll share my screen now. So looking at a systems approach to assessing critical facility functionality post-earthquake, with a focus on hospitals, since they're a critical facility that we kind of expect to be functional after a major earthquake, but is not necessarily proven to be functional afterwards. So just a general overview about my larger research area overall. I do community resilience research, looking anywhere from overarching community resilience and getting an idea about how a city or a community is going to respond to a disaster, to looking at individual facilities such as a hospital. How can we break them up into components and then analyze them as a system to figure out potentially what their functionality or recovery time after disaster is, down to smaller structures like backcountry huts. I'm an avid tramper, so I like to include some of my recreation in my research as well. So general outline of my presentation today, I'm going to talk about my motivation for looking at hospitals in particular and essential facilities, go over what I like to call resilience-based earthquake engineering, which is a methodology that's been developed to help look not just at damage and downtime, but also about how can we ensure our facilities are functional. Go over a case study that's looking at a hospital, and then talk about how we can then use our resilience-based earthquake engineering to quantify functionality. All right, so motivation. So this is an overarching timeline of some events that happened in the US, and deadlines of amendments that put into place there, requiring hospitals to evaluate and be functional after a major event such as an earthquake. A lot of these are California based, due to the higher seismicity in California, but overall kind of a push towards getting essential facilities in the US and then also in New Zealand to be functional after a major earthquake when we need them. And this came after a series of major earthquakes throughout the 1900s, including the San Fernando earthquake in 1970s and the Northridge earthquake in 1994, with deadlines for acute facilities to be functional or to meet these standards of being functional by 2030, or if they don't meet those requirements, then they need to close. So going thinking, well, how can we actually know if a facility is, or at least predict if a facility is going to be functional? These are just the earthquakes that led to different policies in the US that are looking at changing and improving code and requirements. It's a bit out of order. So that leads into performance-based earthquake engineering. So this was developed primarily out of UC Berkeley and the Pacific Earthquake Engineering Research Center, also in the Berkeley area. Really looking at a procedure, a probabilistic analysis that looks at a structure from the design through a hazard, a structural damage, and loss assessment to determine how much a structure is going to be damaged, what the potential losses in terms of repair costs and recovery time are going to be, and kind of a cyclic approach to reducing the potential of damage and losses after a major event or whatever event that they're looking at doing. And so my thought process is, well, this gives us a good idea of what damage and losses are, but that doesn't necessarily tell us about functionality or what functionality of a system is, in which case we need a little bit more understanding of the system, which takes into resilience-based earthquake engineering. So first, with resilience, at least from civil engineering point of view, it's been developed by looking at measuring functionality of a system over time. So in an engineering context, we often consider a system to be resilient if it's robust and able to prevent disruption of functionality, and is able to have fast recovery or fast restoration of that. It's also been defined by a couple of different people. This slide is just showing some of the seminal definitions of resilience models, all showing kind of this functionality curve where we're looking at our y-axis, showing some level of performance or functionality of a system or a building, and our x-axis giving an indication of time. With these, we all of them kind of show a pre-disaster functionality, a stable state that we're working at, until we reach some sort of disruption or disaster that happens, and that's going to cause some drop of functionality. And that drop's going to be measured by how resistant our system is, based kind of on robustness and redundancy that we have in our system. And then we're going to have a response and recovery time. And the shape of this curve is kind of indicated by how resourceful our system is at picking up and recovering or implementing resources. So this goes into my resilience-based earthquake engineering procedure. So the first 4 steps or 5 steps really here. So from design, hazard analysis, structural analysis, damage, and repairs. That's all part of the performance-based earthquake engineering, where we're probabilistically looking at what are the potential hazards, what's the analysis results we can get, what are the damage, and what are the repairs. And then using the damage and repairs that we get from the performance-based analysis to do 2 more steps. The first step being an operability analysis. We're looking at individual subsystems of a larger system being able to operate, and then a resilience or functionality analysis where we're determining resilience by plotting functionality of the entire system. So we sum up the operability of the subsystems to get a functionality at each point of time. We repeat the process throughout the recovery period to get a map or a curve of the functionality over time, which is a measurement of resilience. So implementation of this, so case study, I did looking at, throughout my PhD, was looking at a hospital based in San Francisco. 9-story, quite large acute care facility that housed everything from operating rooms in the basements up to medical and surgical to palliative care up at the ceiling. And the idea is this building is being built to be functional after an earthquake, but is it actually going to be functional? So going through a hazard analysis, you're just trying to figure out what the potential hazard is for that area, what's the potential earthquake we can have. From there, selecting a suite of representative ground motions that we can look at so that we can get an idea of the probability of some sort of damage, and then from that damage, from that level of shaking, put that into a structural analysis. And doing a structural analysis, I was comparing 2 models, a fixed-based and fixed-based with moment frames, So that's just a standard typical a building design. And then a base isolated, where we're putting base isolators at the bottom of each of the column connections, or the major ones, and physically isolating the structure from the ground. And we wanted to compare the performance to see if a base isolated structure is actually going to have better functionality, or if there's also potentially other things that we need to consider in the design of this hospital. So with the structural analysis, what we're looking for is getting our average drift and our average acceleration. We get this across all the floors, so the basement and above ground floors that we're looking at, calculating the maximum drift of each floor as well as the peak acceleration. Drift gives us indication of damage to our structural components, while acceleration gives an indication of damage to non-structural components such as our wall partitions or our suspended ceilings. Next, doing a damage analysis. So this is the next step of the performance-based analysis. We wanted to look at each of the different components based off of either if they're drift sensitive. So in this case, I was using wall partitions that were represented as drift sensitive, and then suspended ceilings for an example of an acceleration sensitive. Doing a damage analysis, we were looking at cumulative distribution functions to give an indication of damage. So we take in our drift for each floor, take it in at the Y or at the X, go up to where it intersects the curves, and that's going to give us a probability of what damage state we're in. We do this for all of our structural and non-structural components for our earthquake, and we're doing this over numerous simulations so that we get kind of a probabilistic idea of what type of damage we're going to get for our structure. This is showing the damage between a moment frame and the base isolated frame, where the damage are kind of separated between either no damage, which is the dark blue, which we see a lot of in our base isolated, and then three different types of repairs, either repairs that are required for reoccupancy. So that's when we can physically get back into the structure, not when we can use it, but when it's safe to be inside the structure. Repairs required for functionality. So that's looking at when can we use that building as its intended purpose. And usually functionality, often it's defined as full functionality of that system or of that building. And then repairs for full recovery are just like the minor repairs, like maybe a cracked wall that's not hindering your ability to actually use the area, but you'd like to get repaired for aesthetics or to get it back to like new situations. Using our damage analysis, we can then look at a loss analysis. So this is looking at downtime in terms of how long it's going to take to repair our building or structure, and as well as cost. So what's the financial cost for getting the repairs? Looking across each of the floors of our structure and where a component is located, and following some repair schedules have been proposed by people at AREP as well as through FEMA in the US, get kind of a basic repair schedule that we can estimate how long it's going to take to recover based off of the amount of damage, where the damage is located, and what type of damage it is that we're looking at. In this case, we're seeing our moment frame, we're seeing interior damage across most of the floors, mechanical damage where it's located, so that's like our HVAC systems, and then we see a big issue with our elevators, with our moment frames. On our base isolated, we see that long one there at the bottom is a stair issue, and that's mostly due to the isolation of the building, and there's stairs down at the basement having a mesh problem. But then if we're looking at repairs in terms of our internal and our mechanical damage or electrical. It's a lot less in our base isolated, which we would expect for that structure. So what does that mean in terms of operability? So to determine operability, I use fault trees, where I'm looking at dissecting a system, and in this case, I'm defining a system as an individual service within a hospital. So these are service areas such as emergency department, operating rooms, sterilization. They're looking at both clinical and non-clinical areas, create a fault tree for each of the different services within the hospital. So this is a generic fault tree for a service where we're looking at defining basic events for our system down at the bottom, and then we're propagating up through the fault tree using these and and or gates. This level, based off of the results that we were getting in the previous steps, we're running this through deterministically. So we're assigning and or true and false values to each of the and or gates. Our basic events is what we get from our loss analysis, and then propagating those up through our fault tree just using binary logic, we'll be able to get if our service is disabled or if it's not disabled up at the top. So that gives us our operability for one service at one point of time. We then repeat this process for every service we have in our hospital for each period of time in our recovery. And then we generally do this for a large number of iterations or simulations to make sure that we're reaching convergence and can get a representative idea of what we're going to be getting for our damage or our operability. After we do our operability, we're going to combine these for each of the services. So looking at the different services or areas of the hospital that are physically located within that structure. This isn't representative of all areas we would have in the hospital. A lot of the clerical services and non-clinical services are located in a different building, so they weren't included within this analysis. So just the buildings, so based off of their location, could map the damage to that location and then determine if that service was going to be functional or not. So looking over the period of time that we have for recovery, so about 16 days, it's estimated for repair time for completing all the repairs. We can get an idea about what services are inoperable, shown in red, and which ones are operable, which is shown in green. Combining those, so just summing those up or doing some sort of weighted average based off of what services are more important, can give us a basic idea of a hospital's functionality over time. Which would give us a resilience curve. So plotted here is these resilience curves showing our functionality for moment frame and base isolated building. Moment frame is a little bit more interesting, and we're showing 10th, 50th, and 90th percentile of curves for different recovery periods that we could have for our structure and how much functionality we're getting restored as repairs are completed. And this is assuming that as soon as repairs are completed within that service area, it's going to be able to start operating at full functionality. There's limitations to that assumption, but it's a first basic assumption that we can use as a baseline for a first line functionality of a system. With our base isolated system, we do see a small blip drop of functionality for our 50th and 90th percentile. It's an indication that there is potentially some damage, and just due to the level that I was able to look at repair times and discretizing, it just showed us a small blip where there's going to be some minor damage and then some minor repair time for inspections or getting people down. In reality, you probably wouldn't be losing that level of functionality because that level of damage might not be noticeable or needed for repairs. then once we have that, how can we quantify functionality? So it's more than just looking at those resilience curves, but what do those resilience curves mean? So part of it is going to be what we have for our fault trees. So the accuracy of our fault trees in representing our system is going to change the results that we get for our system. So in this case, I've changed this fault tree just slightly. So where the previous one was just looking at damage in the area where the service was located, and wasn't necessarily accounting for damage to, say, mechanical or electrical equipment or HVAC, where it was damaged and affecting the overall building functionality, but not necessarily being seen by that service area because it wasn't physically co-located in that area. So rearranging our fault tree so that we're better able to capture that types of damage, and rerunning the analysis, we're able to get some slightly different results, especially if we highlight on some of the different components that have more of an impact. So HVAC system, we could think maybe not necessarily important. I know University of Waikato doesn't really think HVAC's that important for us, not providing heating or cooling. But hospitals, it's a little bit more important to have HVAC, both for positive and negative pressure in ICU rooms or infectious disease control. Also, large buildings, critically ill, or even older patients, young patients, unable to regulate body heat as well. It's really important that HVACs are operational for facilities. So looking at the moment frame building, in this case, I'm looking at on the left where we have our moment frame with our confused by my cursor really quick. So on the right, that's incorrect where it says updated fragilities. That's showing the original fragility. So not fragility curves, sorry. Confusing myself, sorry. These are showing the latest version of fragility curves by FEMA P58, but on the left, it's showing the original resilience curves that we had for our system with the original fault trace that we were looking at. On the right, we're looking at the same moment frame, but we're looking at the second fault tree where we're better incorporating the need for HVAC for a lot of services for that to be working, and recognizing that even though it's not physically located in the same area, that damages or outages of the HVAC are going to be affecting that service level. In which case we see a drop of functionality, and it stays down until the HVAC is repaired, at which case we see a restoration of functionality, in this case estimated to be about 15 days. Second thing is looking at elevators. So elevators in hospitals are also critical for moving patients up and down. If you can't move patients, from emergency department that's typically on a first or a ground floor to a surgical area that's generally on a different floor, it's very difficult to admit or treat those patients if you're having to carry them up and down stairs. So elevators are critical. Elevators have some sensitivity issues that can be quite problematic in base isolated buildings. And so this is showing that if we're looking at elevators, even in our base isolated building, if our worst case, we lose our elevators and we have to wait for the elevators to be restored, we're going to have a dramatic drop in functionality. This is kind of showing a worst case. So over here on the left is showing with the new fault trees. The one on the right is just looking at it where elevators, because they're not physically co-located, we're not seeing that drop of functionality. On the left, where we see a prolonged absence, in this case, it's waiting for all 11 elevators in the building to be repaired. In reality, we would see some return of functionality happening much sooner. As soon as you get 1 or 2 elevators operational, you're able to restore some level of functionality. So again, this is kind of highlighting some of the issues with initial round functionality where it's kind of binary, it's either on or it's off, not really capturing different levels of functionality within a system. Other components within a system that can be problematic include ceilings. So depending on what type of ceiling systems you're using, your suspended ceilings and your repair times can have quite dramatic impacts to how much that's going to be affecting your recovery time. Again, with that functionality, it's going to be considering on an area by area basis how important those ceiling tiles are for functionality. Can you use that space if you don't have ceilings? Tiles often for like an office space, yes, you can. For a patient area in the hospital, you might have low dust requirements, or you need them for keeping pressure within that space. So there's needs to be more research in that area as to how that's going to be affecting different areas. Utilities can also be indicative. So a lot of places in the US and here require 3 days of backup power, but often our utility outages are going to be much longer. And in this case study, we're seeing longer than 20 days before we were able to get utility backups, which is going to cause quite extended delays if we don't have enough backups in our system. So the bottom right is showing our system if we don't have any failures in our utilities. So assuming everything's our water, power, medical gases, those are all working fine, where the recovery is just going to be dominated by the damage to the physical structure. If we have no utility backups, then we're going to have quite extended delays while we're waiting for other systems to get operational. This again could change if we bring in different things like outside water or like a big generator. But without being connected to mains power, even a generator is probably not going to be able to operate at the full level of functionality of a hospital. The other 3 are showing kind of a combination of having water and power for different numbers of days and how that's going to affect our system. The other thing that's poorly captured is when we're looking at repair time. Often what's neglected is the impending factors, so how long it takes to do inspections, to engineer, mobilize engineers to get supplies. And if we consider that, that's actually going to be adding some amount of time, depending on what type of contracts and supplies are available. And often that's neglected when you're looking at functionality. And this is, even a base isolated building can have some of these impending factors that are going to be reducing that functionality over time while we're waiting for different things to happen. So some of the challenges highlighted a little bit of these already. So the results here are binary. It's either on or it's off. So functionality is quite basic. The inputs are deterministic. So we're putting true false values in instead of probabilistic values. And then our results are not necessarily representative of true losses of function, but they are representative of some loss of function within a system. So further work or objectives to do is to look at providing real-time information to hospital staff about functionality of their departments after disaster. To provide an overview of critical staff and space components, so main components within a hospital area, and to account for partial functionality by using combined event trees and fault trees. So this is current ongoing work that we're looking at to try to get more realistic evaluation of what levels of functionality we can get for facilities, and how that can be communicated to staff. So methodology for this, looking at creating a hospital functionality database. So because earthquakes don't happen all the time, thankfully, we can't necessarily play around by looking in testings, but we can look worldwide to see how have hospitals performed due to earthquakes and other disasters due to damage to the physical environment. And then developing some event trees and fault trees. I'll go over those a bit. So blue is stuff that we've worked on developing a lot. Green is areas that are ongoing. So once we've developed event trees and fault trees, we want to apply probabilities of occurrence for this so we can get probabilistic estimates instead of just deterministic. Consult and validate, so work with the hospitals and district health boards to see if this is realistic for their expectations, and then create a dashboard for communicating this information. So with this functionalities database, we're looking at gathering information from earthquakes, hurricanes, tornadoes, other physical disasters that have caused damage to hospitals where we've seen some sort of outage or drop of functionality. So this is showing some of the information that we're collecting. So for an Anchorage one, we get basic information about the earthquake and the hospitals within the region, geographical location about where it is, injuries, damage, and then we look at what information can we find that's been published either through clearinghouses, news reports, hospital websites about damage to different structures. So here we have some pictures of physical damage to different parts, both non-structural and structural damage, as well as reports about some types of damage within the areas and any reported loss of functionality or closure of the service. Using those, we're able to use those as data to help us create our event trees and our fault trees. And we do that in conjunction with looking at hospital guidelines and standards, as well as operational procedures for hospitals. So with the event trees, we're looking at a series of events, starting with an initiating event, and then events after that that are either going to happen or not going to happen. That's going to lead us to different end states. And in our case, we're going to be defining those end states at different levels of functionality. And then we have our fault trees as before, where we're going to be looking at defining a fault tree for different areas of a hospital or different services. And so then we can combine the event and fault trees so that we can get more information. So combining event and fault trees is commonly done by places like NASA to get an idea about their shuttles or their rockets to ensure that they're going to be safe. Fault trees by themselves have been commonly used in the literature to illustrate events that lead to hospitals being rendered unfunctional. But it's generally they're rendered completely non-functional if one minor component is unavailable or non-functional. And so by combining event trees and fault trees, we're hoping to get accounts for partial functionality, trying to reflect what's more likely to occur. So we're going from just binary that we're getting with our fault trees to kind of a more a gradient view of what we could potentially get. So with our event tree development, develop this all out, we're looking at different events that are going to be causing issues. In this case, we're looking at different states that we could have. So we could think about this as different functionality states, such as patients being evacuated, limited access, or partial. Reasons for why that's happening. So what's happening either to our our hospital or to an area overall. We can categorize that, so we can look at, if patients are being evacuated due to pipes, that's going to be an issue with utilities as well as with the space, so the physical space. And then we can then look at a top event in our tree. So that's going to be a top event of a fault tree. That's going to be leading or identifying an event in our event tree. Dependencies, here we're going to look at how dependent one area, so what our categories are on others. So a higher level of dependency is going to have a higher link to that functionality. So a 0, it's not impacting functionality, up to a 4, where we're going to have complete impact on our functionality. So we use this to order or sequence the events within our fault tree. So in this case, we're looking at, our event tree. Our event tree, we're looking at going from our disaster events happening, and then we're looking at a series of questions going from, do we have space available, medical staff available, and vertical egress, just as a basic one that's going to be giving us outcome, which would be a different level of functionality. So thus far, we've looked at developing our fault trees for 32 areas relating to an emergency department functionality. We've also looked at other areas of a hospital, and then we've created sequential event trees for an emergency department and an entire hospital where we're considering structural, non-structural, and utilities. So we're combining them. So we're using our fault trees, which shown on top, an inverted fault tree for a building being unsafe, being reverted down. So you do the fault tree, you're going to get a value. The building is unsafe or not, then that's going to go into your event tree to trigger, at this case, a deterministic value, yes or no, that would then indicate where you're going to go here. In this case, we have switched around this order just slightly. We're putting medical staff availability first, followed by buildings. They're a bit interchangeable, medical staff and building being unsafe, as a loss of both is going to lead to a complete loss of functionality of our structure. Looking at that overall, so this is for an emergency department. We're looking going from medical staff availability, looking at structural damage, non-structural damage, major and minor utility losses, supply availability, and auxiliary services. To be services that emergency department is going to rely on to be able to continue functioning. Loss of some of these isn't going to lead to a complete drop of functionality. It's just going to reduce what you can do within your emergency department. And so with that, we're going to be looking at different functionality levels. So going from either no functionality because we have no staff, no functionality because our building's been red or yellow tabbed, down to reduced functionality, either due to a drop of bed counts, reduced functionality because we can't do as many services due to power issues or damage to some equipment, reduced functionality due to supplies, or potentially longer wait times due to reduced capacity. So we can get there some better indication of a functionality in a non-binary sense. And then we can look at seeing what that looks like for a hospital or an example. So using data from the Christchurch Hospital and their emergency department after the February 2011 earthquake, can get an idea of a functionality not just based off of availability of services or departments within a hospital, but based off of utilities and capacity to do a service. And here we see over 72 hours, there is some reduction. So we're going to have some residual functionality that remains immediately after disaster. Then we're going to have some sort of reduced due to some damage to utilities. In this case, the backup power was restored quite quickly, but it took a while for main power to be restored. So you're not going to be able to do everything on backup powers that you can on main. Then our next jump going to occur when our main power is restored. We still don't have all of our imaging done, but when that is done, we're going to have another jump. But we still have some reduced services because there's some auxiliary services that had outages or reduced capacity that would then be affecting the functionality of our emergency department. So this is all going to go together to create a functionality dashboard where we can look at graphing over here our level of service or our functionality over time. Indicators on the top give estimates of overall for our hospital, what's our functionality, what's potential wait time, for our critical services, what's their availability, looking at different hospital departments, looking at them specifically, what's working and what's not working, with the idea that this could be used in real time after a disaster to get an idea of when things could potentially be restored or what level of service you're going to have right then, or as a planning or preemptive approach, or if you say, well, we analyze our building, we're predicting these types of damages, what's that going to mean for our functionality after the earthquake? So future directions, just really continue this work and look at comparison between a couple of countries as well as lived experience within New Zealand. And then finally, looking at incorporating some probabilistic values into the fault and event trees. So thank you. Just some acknowledgements of funding, supporting organizations, and collaborators with this. Thank you.
Thank you, Megan. We've got a few minutes for questions. I think that we've had a number of folks tag out. So if you're interested in asking a question, I hope that you will either put your hand up or come off mute. I can see, I'm keeping an eye on that there in the chat. While we let some folks get their thoughts organized, like right off the bat, like this is a really cool way of looking at critical infrastructure and measuring resilience in a way that is understandable, right? It's not a fluffy concept. It's not a there's no debate. It's really based around how quickly how much capability can we deliver while we're in this affected state, and when can we get back to full capability later. Do you have any interest or plans in expanding this kind of analysis to other types of critical or really important infrastructure, like airports or
yes,
transport systems or anything like that?
Airports is definitely an area that I have looked into. I was working with a student last year a little bit on it, especially after the floods in Auckland causing issues and drop of functionality there. Airports is definitely another area I want to look at, and I am looking at other areas because post-COVID, it's actually become very difficult to work with hospitals, and it's a bit over capacity, I think. I've lost a lot of my connections with hospitals since COVID, and I've struggled to rebuild those. So I am looking definitely at other critical infrastructure, transportation systems, and places to look at.
Cool. And I know that a couple of other people have come off, but one more thing, this same kind of analysis could be used to, explore resilience in supply chain. One of the, speaking of COVID, one of the things that drove everybody kind of crazy is that some stuff just wasn't available. You couldn't get it. And you couldn't get it, and it was like unexpected, right? And so having that, I could see civil defense having a real interest in understanding, how do we make sure that we're prepared to operate through and recover from supply chain types of disruption using exactly the same sort of analysis. John came off, put his camera on first, and then we'll go to Nick.
That was a great presentation. Thanks very much, Megan. That was really interesting. Certainly when the inter-islander resilient connection was a thing, that would be the kind of analysis that would have been really interesting to apply to that sort of a project, especially given the title. I had a question around you. It sounds like all of your analysis so far has been quite deterministic, as you mentioned, and you're looking at probabilistic extensions to it. Do you have a feel for how much that's likely to affect your results if you were to put probability distributions and perhaps they're not symmetric, that kind of thing? Do you feel like it's going to impact the results you've got so far?
So I don't think it would affect too much, at least of the stuff that I've looked at with hospitals. And the reason for that is that so everything through the performance base, so everything up through the damage and loss was probabilistic. And with that, I took values from 2000 results and ran them through. So I just need to get the distributions that you would get for each of those and get a probability they would run. But I don't think it's going to change the results too much because it is looking not just at one case study, but looking at a summary of what we're getting under 2000 simulations.
Thanks.
Nick.
Yeah, thanks, Megan. Enjoyed that. And I think even down to IT systems, I worked for a datacom at one point, and during doing this sort of thing during, trying to keep data centers alive, they're very good at it. But during the Christchurch earthquake, even though they had contracts to make sure people would deliver them fuel to keep the generators going when they didn't have power to run the data centers, they realized, contracts don't mean anything in an emergency. So it highlighted which things going forward, the company would invest and try and control themselves. So instead of relying on somebody else to bring us a tanker of fuel, they bought their own tanker and trained their own people up to drive those tankers and trained many of them rather than just one. So they didn't have a single point of failure for someone who wanted to run off and save the kids, which is reasonable.
Yeah,
doesn't matter what's in your contract, you'll in an emergency, things happen. So it's quite interesting to see about those decisions of where do you spend your money. Is it in spares, is it in parts, is it in more people capable of doing the job? So I think it's fascinating.
Thanks, Nick. I think that what's important here is that it does kind of highlight or allows people to see where the weaknesses are, so that you can put in the redundancies like you've mentioned.
Brilliant, thank you.
I think, Luke, you'll be our last question for the evening before we wrap it up.
Yeah, Megan, thank you. Great presentation. I suppose a question not just for you, but maybe for the floor generally, and Jess, you kind of touched on it a little bit earlier. But I'm curious what people's thoughts are on perhaps the reusability of that model. So if you take the word earthquake out and put in system, resilience-based systems engineering, to what extent could we use this model or methodology on sort of systems in general, not just sort of structural systems, but maybe electronic systems, space systems, that sort of thing? I suppose, yeah, general kind of talking point, I guess.
So when I was listening to Megan, I had all sorts of thoughts running through my head. If you can parameterize the capability of a system and identify the components that are necessary in order to deliver that capability, then you can do this kind of analysis. I think this kind of analysis is directly applicable. You have it for some more complex systems that may be more challenging to express, especially if you end up with components whose collective capability is interdependent. But I think that, you know, I would be really excited to see other ways of applying something like this.
Yeah, because I was thinking when you've got the structural analysis there, I mean, that could be replaced with a system architecture analysis or something like that. And yeah, I'd be keen to, yeah, see different variants of the model being applied. So yeah, very interesting.
Thank you.
Thank you.
Fantastic. Well, with that, thank you, Megan.
Thank you.
I'm gonna grab screen share from you and just remind those of you who are still with us that our next event will be the AGM on 30 April. Again, the event itself will be lunchtime, so that folks who are working, so we got some feedback last year that middle of the day might increase the likelihood of folks making it to our meeting. Unlike our meetups, we need a quorum for AGM participation. So we hope that you will make it a priority to be there and to vote on the motions and all that good stuff. And of course, social event that we're coordinating sort of across the country after the fact. Finally, again, thanks for your attendance. Thanks for your participation. Thanks, Megan, for your presentation to us tonight. Thanks to the folks who asked questions, and thanks to everybody who's helped make INCOSE New Zealand a pretty cool place to be. Have a fantastic evening, everybody, and see you later.